So invite Dr. Jayakrishnan sir. He's a additional professor in pediatrics and expert in PICU care at Calicut Medical College.
The topic we are dealing with the next is poisoning experiences from pediatric ICU. I'd like to introduce the chairpersons once again. It's Dr. Samuel Koshi. He's a consultant pediatrician of Maulana Hospitals, and Dr. Sunil Kumar Menon. He's associate professor in pediatrics at Amala Medical College, and he's also the past secretary of IAP Thrissur. I request the chairpersons to introduce the topic.
Poisoning, we all know. It's so common that almost all of us might have treated poisoning in our ICUs or even in the wards also. But types of poisoning, treatment of poisoning varies from individual person to individuals. To highlight on this, we are having an eminent speaker here, Dr. Krishna.
Next one is previous.
Over to you, Dr. Krishna. Jayakrishnan, sorry. Over to you, Dr. Jayakrishnan.
Good afternoon, and I take this opportunity to thank the organizers for giving me this opportunity, and also congratulate them for organizing this conference in such a wonderful, fantastic way, the wonderful hospitality also. And Dr. Akbar started his talk on autoimmune encephalitis by narrating an example of poisoning. So poisoning is something which can present with many ways. Like it can be like it can look like a sinus trauma. It can look like a sinus infection. It can sometimes look like a metabolic problem, or it can look like septic shock, myocardial dysfunction, or whatever. And when we think of talk about poisons, I'm always reminded of Agatha Christie, who has written crime novels and many of her novels. In fact, she is the person who has described poisons the maximum as far as crime fiction is concerned. She described 30 poisons in her novels, which people used to kill people. And in the next 15 minutes or so, I'll try to take you through our experience in the pediatric ICU of Government Medical College Kozhikode during the past 10 years, and also narrate some of the issues that we come across in managing them. This was a 4-year-old boy. This child, in fact, was admitted about 10 years back in our hospital. Ingestion of Abrus precatorius seeds, kunnikuru, and brought to the hospital about 6 hours after ingestion. He was having stable vitals at the time of admission. We kept him in the ICU for 1 day. Next day, he developed loose stools and vomiting, GI symptoms on the second day, multiple episodes, and then he was managed with IV fluids, but still he was remaining stable, and he was apparently recovering. And the 4th day, we were planning to discharge the child. The house surgeon had in fact started writing the discharge summary, and at that point of time, he developed one episode of seizure and had a sudden cardiac arrest and died. This was something which we never expected. But then, when we looked into the literature regarding Abrus precatorius, such kind of sudden death is possible. And we don't know why they have this, most likely related to some cardiac arrhythmia. And this is our experience during the last 5 years. It is between 2013 and 2017 in the pediatric ICU. We had close to 300 cases, 297 cases, and most of them were under 5 children, less than 5 years, almost more than 80%. And the commonest poison as a group was antipsychotics. And among the antipsychotics, the atypical antipsychotics that we see, like olanzapine and clozapine, most of them. And the second agent, as a single agent, the commonest obviously was paracetamol, 42 of them. And that was followed by rat poison. Rat poison means, when I mention rat poison, it is zinc phosphide and yellow phosphorus. Almost 36 of them. And only one death we had, and that was related to yellow phosphorus poisoning. And this data between 1999 and 2003 was collected by Dr. Krishna Kumar from our hospital. Comparing that with the data between 2013 and 17, there is a significant reduction. The number of cases, almost from 1,300 to 297 now, during the last 5 years. And the commonest poison at that time, about 15 years back, was kerosene. As expected, the kerosene injection poisoning incidence has come down dramatically from about almost 50% at that time to about 10% now. But then the poisoning related to this particular poison, rat poison, that when I say rat poison, it is yellow phosphorus, has actually increased the percentage-wise. 4% has now come to about 12%, and it is causing mortality also. That's the only mortality that we had related to rat poison. And the vast majority of poisoning in children are accidental. They ingest these poisons accidentally and come to our hospital. But then deliberate self-harm is also possible with poisoning. And in fact, in this series in 2011, published by again our Dr. Krishna Kumar, 25 out of 30 cases involved suicide attempts. It involved poisoning. And like any other sick child coming to the emergency, you take care of the airway, breathing, circulation, and other things. And the history is also important. As I mentioned in the beginning itself, it can present in many ways. Like, for example, we had one child who came with seizures, a 10-month-old, was brought to our emergency, and we didn't know what the cause was. Mother also did not give any other history, like child didn't have fever or no other predisposing factors were there. And when the resident considered the rare possibility of poisoning, she thought of doing a gastric lavage, and there was a strong smell of camphor. So this child had come with seizures, and gastric lavage was suggestive of camphor poisoning, because this child was taken to a nearby place where a puja was taking place, where he went to a god man's place, and this karpuram, this camphor, was came in contact with this child, and most likely she might have ingested it, and that has resulted in seizure. So this presentation can be highly variable, and any child with a sudden alteration in mental status, for which you do not know the cause, always think of this multiple organ dysfunction without any other cause. And history-wise, sometimes if you actually ask leading questions like this, you might sometimes be able to pick up the reason. This was a 9-year-old girl referred to a hospital with history of vomiting and 2 episodes of seizures. And there was no apparent, like the other child, no apparent cause. And but then within half an hour, 2 more children was brought from the same locality with the same symptoms like vomiting, but no seizures. And when we asked the history again, they came with the history that they had ingested this particular seed, the thani. You might be knowing thani. It's supposed to be an Ayurvedic medicine. That is one of the components of Triphala. That's an Ayurvedic medicine. But this particular child, 9-year-old girl, 3 hours post-ingestion, we didn't expect anything, abnormal to happen, but then suddenly developed generalized seizure once again and had a sudden cardiac arrest and died, unfortunately. But the other 2 children made an uneventful recovery. The other 2 children didn't have any problem. And the house surgeon, the resident who actually recorded this rhythm at that time during the seizure was showing something like this. Can you identify this? We had a discussion on ECG the other day, 2 days back, for the pages. This is actually wide complex tachycardia, polymorphic. This generally indicates a long QT condition. And we had an ECG. This is, in fact, not the ECG of the child. This ECG is that of the father. Was showing a prolonged QT interval. And we did a genetic study on the father and siblings and the sibling, and that was positive for a mutation for long QT syndrome. So there are certain predisposed children who can have dangerous arrhythmias when they get exposed to drugs or vegetables like this, which can prolong the QT interval. So we need to consider that also. It's always a good idea to get an ECG done in all cases of poisoning, because there are intervals, we call it intervals, PR interval prolongation, QRS interval prolongation, QTC prolongation, all can suggest the certain specific types of poison, which is highly helpful. And the management of poisoning includes these broad principles, supportive care, antidotes if it is available, then decontamination and elimination, things like, and ABC is very important, supportive care is important, but then if child presents with shock, always consider the possibility of associated myocardial dysfunction also. So for pushing in fluids, you have to be careful about that. You have to monitor the child for development of fluid overload, and of course, you need to expect arrhythmias also, life-threatening, like what we saw in the other child. And there are specific antidotes available for many of the poisons. For paracetamol, rat poison. Rat poison, N-acetylcysteine, we are not very sure, but we have the experience of giving N-acetylcysteine for our cases, and we didn't have any problem. I mean, we all our children survived, except any pain. I mean, respond in a moribund state, response only to pain. The child was in cardiopulmonary failure, hypotensive shock, and ABG was showing severe metabolic acidosis, and we managed it in the usual way with boluses, inotropes, and mechanical ventilation, and given the history of iron tablet injection 2 days prior, we started the child on desferrioxamine also, but we could not do anything about the child. The child died within, I mean, on the second day of hospitalization. So what happened actually? The child had ingested an unknown number of iron tablets, which was actually supplied by the Anganwadi teacher to the pregnant mother, and those days iron tablets were available as loose tablets. There was an NRHM program which was supplying iron tablets as loose tablets, and this child, mother gave all this, or the child took by accident, we don't know. And what happened was the child had GI symptoms immediately following the event, I mean ingestion, and the child was taken to a primary health center where she was treated symptomatically with IV fluids, and there was symptomatic improvement. And in the evening, the treating doctor told them that they could go home. And there was an asymptomatic period for 1 day after that, and then the third day, child came with cardiopulmonary failure and died. So this is what happens in severe toxicity with iron. There is a symptom-free period in between. That you have to be always careful about in iron poisoning, which does not mean that the poisoning is not serious. So you also have to, after the initial symptom-free period, the child can go in for multiple organ dysfunction and can die. So during the years, those years are not coming there, unfortunately, I don't know why. This starts from 2007, 2008, 2009, you can see that. So 2007 and 2008, we had the maximum number of cases of iron poisoning, and that was a time when iron was supplied as loose tablets to Anganwadi teachers, and most of the children were under 5 children having ingested this accidentally, and we had 4 deaths in 2007 and 8. Those light green there on the first 2 plots are deaths. And so we had total of 4 deaths, 28 cases in just 2 years. But after that, 2009 to 2017, 2018 now, no deaths and only about 3 or 4 cases per year. You can see a second peak there towards the end of the graph. The second peak, unfortunately, the years are not coming there in the x-axis there. 2014 onwards, there's a slight increase in the number of cases again. Most of them older children in the age group of 10 to 12 years, when actually the government started a new program, that is a weekly iron folic acid supplementation program, and more children, they sometimes, a teacher is supposed to give only 1 tablet to the child every week, but what happens is that all the children sit together and they have some kind of bet or something, and then who will eat the maximum number of tablets, so many children were admitted with iron poisoning at that time. So what we did in 2007-8 was that we contacted all the DMOs, Kannur, Malappuram, Wayanad, Kozhikode, and discussed this problem with them, and the training programs were in fact arranged. Dr. Ashraf knows. So we could, they conducted training program, and that actually has shown a dramatic reduction in the number of cases of iron poisoning getting admitted, and I think that might have saved many lives also. So loose iron tablets. Now the iron tablets are no more supplied as loose tablets, and as I mentioned, initial gastrointestinal symptoms are followed by a symptom-free period. You have to be very careful about that. Symptom-free period doesn't mean that the child will not have any problems in iron poisoning. And any child having ingested more than 40 milligram per kilogram, you have to assess and decide whether the specific antidote desferrioxamine is indicated or not. Unfortunately, desferrioxamine is not available freely in our place now, and only one company actually supplies that, and last time when a child came, we had to get it from Ernakulam. It took a very long time for us to get the medicine, and so you can try other things like bowel decontamination, like with whole bowel irrigation and specific antidote obviously is desferrioxamine. So the child is symptomatic, you always have to treat that. There may be sometimes visible iron tablets seen in the X-ray. Any child having ingested more than 60 milligram per kilogram should be subjected to whole bowel irrigation. And indication for desferrioxamine if there are severe symptoms, acidosis, coma, seizures. If this kind of X-rays, the iron tablets are visible in the X-ray, or if the serum iron concentration is available, if it is more than 90, you can start the child on desferrioxamine. And till the child is asymptomatic, till the acidosis is resolved and the serum iron is less than 60, you have to continue that. Generally, desferrioxamine is not continued for not more than 24 hours. Is anybody in the audience using this particular formulation, P500? That was introduced some years back, 2 or 3 years back by this Apex company. Just after a week or so after this was introduced in the market, we had a child, a 6-month-old baby who was given 5 ml 6 hourly of this paracetamol, had severe features of GI symptoms. And so this actually, I think, I don't know whether we should, the drug controller should allow this to be marketed at all because there's a very high chance of poisoning taking place with this. And again, for paracetamol also, only point I wanted to highlight was that, again, for this also, there is a symptom-free period after the initial GI symptoms. So never reassure the mother and discharge the child. The child comes with GI symptoms, always make sure that you have maybe started the specific drug like N-acetylcysteine or done the proper management. And any acute ingestion, generally acute ingestion is not a problem for us. Like for suicidal kind of ingestion, which is the most common poison that they use in the West for suicide attempt, is not there in India. But then accidentally mother can give it. The problem here is that the mother might have been giving this paracetamol for 2 or 3 days prior to that also, because child is having fever, she's giving it. Then in between the child ingests accidentally a large amount. So, and the paracetamol level estimation unfortunately is not available for us in Calicut, so it's a problem. So we don't generally depend on the Rumac-Matthew nomogram for actually deciding to start paracetamol. Generally, if there is a history of ingestion of a large quantity, we start them on N-acetylcysteine. That's the algorithm. And multiple therapeutic ingestion, like for 2 or 3 days, if the very high dose is given also, it's a dangerous thing. So this child, ADHD, this child in fact came recently, 2 or 3 months back to a hospital. Early morning he gets up and after some time tells the mother that he has ingested 20 tablets of clozapine, 100 milligram. It's actually a lethal dose according to the toxicology book we referred to. In 1 hour the child was brought to the ER, gastric lavage was done, and tablets were there, but he was responding only to pain. There was excessive salivation. These are the things that we usually see in like anticholinergic symptoms, like pupils were dilated. Sometimes pupils can be constricted also in clozapine. Clozapine is a very common ingestion among the antipsychotics for us. And he was in hypotensive shock. And after a few minutes, 1 or 2 hours after coming here, after a few minutes, he, through generalized seizures, was treated with boluses, for lorazepam. And the ECG was showing something like this prolonged QT interval was there. Clozapam and all other atypical antipsychotics can prolong the QT interval, and you have to be careful about that. Unfortunately, this child survived, had some extrapyramidal symptoms in the first 2 days, but then made an uneventful recovery. So CNS effects, cardiovascular, antimuscarinic effects can be there. Pupils can be dilated. Sometimes it can be myopic also. And the choice of drug that you use as an inotrope is noradrenaline in this. This one, a 4-year-old child, he brushed his teeth with Stratol paste. Unfortunately, we could not save him. He presented with, again, initial GI symptoms. Again, there was a symptom-free period for 1 day, and then he developed liver failure, then followed by multi-organ failure and died, unfortunately. This is a very, very toxic, again, something which has to be banned. This particular formulation of Stratol contains a very high concentration of yellow phosphorus, and the lethal dose is just 1 gram per kilogram, which is there in this 3%. Somebody brushing his teeth, that can cause death. Again, the reason why I showed this also is that, again, this also has got a symptom-free period after the initial GI symptoms. So now be carried away with the symptom-free period that happens after the first day. This also, and there is one drug which has been tried, that is N-acetylcysteine, which is supposed to be effective in many cases, but we have, in our experience, I found it to be useful. People have tried plasmapheresis also, following rat poison injection. In Global Hospital, Chennai, they are doing that here. I couldn't get see any other report in the literature regarding that. But then plasmapheresis is possibly useful, but we generally use N-acetylcysteine to treat yellow phosphorus poisoning, and it is effective. Fatal dose is it is 1 milligram per kilogram, and this contains a very high amount of, this ratol paste contains a very high amount of yellow phosphorus. And there can be a symptom-free period, that I remember always. Later on, they develop fulminant hepatic failure and MODS. The last one, it is organophosphorus poisoning. Ingestion of chlorpyrifos, the usual, the cholinergic symptoms were there, salivation, lacrimation, urination, and all that were there. The child came with respiratory paralysis, was intubated, and was started on atropine, the drug. On the second day, the child improved. The child was extubated and was transferred to ward, because the child was absolutely normal, there was no respiratory abnormality, the child was speaking normally, but then the third day again got readmitted. So this is something which you have to be always careful about. There is a problem called intermediate syndrome in organophosphorus poisoning, where the child will have an apparent recovery after 1 or 2 days, and then after some time, again they come with weakness of respiratory muscles, neck muscles, and generally they require intubation again. And prevention is always better, and children act fast, so do poisons, so have to always prevent this, put all poisons out of reach of children, use safety tops, make sure all tops are tightly closed, using safety locks. And we had many instances where children drank kerosene kept in bottles meant for drinking water, not just kerosene. Nowadays it is not kerosene, it is cleaning fluid and all that. Thank you very much.
Any questions? I wish to thank the speakers for the wonderful deliberations. And I also wish to thank Josanni sir, Nandakumar sir, and the team of Manjeri for giving the opportunity to chair the session. And also, it was an excellent conference. Thank you.
I invite Dr. Sunil Kumar Menon to receive the memento from Dr. Nandakumar.